Here is a collection of my videos related to pulmonary embolism. Though the first one is a basic one from my Cardiology Talks channel, others are from this channel. Includes discussion on ECG and echo findings, paradoxical pulmonary embolism, mechanism of McConnell sign, 60/60 sign, CT triple rule out, inferior vena caval filter deployment, intermittent pneumatic compression for DVT prevention, and May-Thurner Syndrome or Iliac Vein Compression Syndrome. What is pulmonary embolism? Blood clots can migrate along with blood flow from various parts of the body to the lungs and block the blood vessels of the lungs. This condition is known as pulmonary embolism. When only small clots reach the blood vessels of the lungs, only a small portion of the blood vessels of the lung is blocked and may not cause any problem. But when large clots or multiple clots migrate to the lungs and block major blood vessels of the lung or multiple blood vessels, it can cause significant problems. Lack of blood flow to regions of the lung cause wastage of air breathed in, which goes back without being utilized for oxygenating the blood. Hence, the oxygen level in the blood falls, causing breathlessness and bluish discoloration of the skin in extreme cases. Blockage of parts of blood circulation to the lung causes an increase in the blood pressure in the remaining blood vessels. High blood pressure in the blood vessels of the lung leads to failure of the right ventricle, lower muscular chamber of the heart, which pumps blood to the lungs. When sufficient quantity of blood cannot be pumped to the lungs, the blood returning to the left atrium, upper chamber of the heart, also decreases, which in turn leads to lower volume of blood pumped into the rest of the body. This causes a fall in the blood pressure of the rest of the body. The individual feels dizziness and may faint in severe cases. It can be seen that massive pulmonary embolism is a life-threatening situation demanding immediate medical attention. S1Q3T3 pattern is the typical pattern seen in pulmonary embolism. This ECG shows the S wave in lead 1, Q wave in lead 3, and T inversion in lead 3, constituting the S1Q3T3 pattern in pulmonary embolism. In addition, there is sinus tachycardia in this ECG. S wave in lead 1 indicates a rightward shift of the QRS axis. Though S1Q3T3 pattern is classical of pulmonary embolism, it is not the commonest. Commonest ECG finding in acute pulmonary embolism is sinus tachycardia. Incomplete right bundle branch block pattern may also be seen in acute pulmonary embolism. Anterior T wave inversion and incomplete right bundle branch block pattern are indicative of acute right ventricular overload due to obstruction of the pulmonary circulation. ECG changes of acute right ventricular overload resolve rapidly with the resolution of pulmonary embolism by treatment and may return to near normal levels as the pulmonary arterial pressure normalizes. It may be noted that similar electrocardiographic findings can also occur rarely in other causes of acute carpulmonale with right ventricular overload, like a major lobar collapse. Echocardiography in pulmonary embolism is useful in several ways. Visualization of thrombi within the right heart or pulmonary arteries would be the most direct way of diagnosing acute pulmonary embolism by echocardiography. Mobile thrombi in the right heart, known as tinea cordis, detected during echocardiography carries a poor prognosis with higher association with right ventricular dysfunction and mortality. In general, the chance of detection of mobile right heart thrombi in acute pulmonary embolism is about 4%, though up to 18% have been detected in certain intensive care settings. Please subscribe to this channel for future updates. Click on the subscribe button. Press the bell icon after that for all updates. Transesophageal echo can detect thrombi in central pulmonary arteries as well. Hence, it may be a useful investigation when patient is too unstable to be shifted for CT pulmonary angiography. The other group of echocardiographic findings in acute pulmonary embolism are features of right ventricular overload due to sudden rise in pulmonary arterial pressure and right ventricular dysfunction. Tricuspid regurgitation jet velocity is useful to calculate the right ventricular systolic pressure by the Bernoulli equation P equal to 4V squared. Main pulmonary artery, right ventricle, right atrium and inferior vena cava can be seen to be dilated in acute pulmonary embolism. Right ventricular dilatation manifests as an increased RV-LV diameter ratio. Relative sparing of right ventricular apex with hypokinesia of right ventricular free wall is known as McConnell sign. It is considered to have a high positive predictive value, though it may not be seen in many cases. A Doppler echocardiographic pattern known as 60 by 60 sign may also be present in pulmonary embolism. In this case, pulmonary flow acceleration time is less than 60 milliseconds and tricuspid regurgitation jet gradient is less than 60 millimeters of mercury but more than 30 millimeters of mercury. Tricuspid annular plane systolic excursion measured by M-mode echocardiography is also a useful measure of right ventricular systolic function. Echocardiographic demonstration of right to left shunt across a patent foramen ovale would suggest the possibility of occurrence of paradoxical systemic embolism and thereby connote a higher potential for mortality. Echocardiography is also useful in differential diagnosis by demonstrating an alternate diagnosis like massive pericardial effusion with cardiac tamponade or aortic dissection. It may be noted that if severe RV hypertrophy and very high TR jet gradients are seen, it is likely to be a pre-existing severe PAH as in chronic thromboembolic pulmonary hypertension rather than acute pulmonary embolism. But a person with chronic thromboembolic pulmonary hypertension can also develop acute worsening due to a fresh bout of embolism. Here are the initial set of references on echocardiography in pulmonary embolism. Remaining references of echocardiography in pulmonary embolism are here. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you. Everyone is familiar with paradoxical systemic embolism. But what is paradoxical pulmonary embolism? Paradoxical pulmonary embolism can occur from an abdominal aortic aneurysm through an aortocaval fistula. The fistula can occur either after a spontaneous rupture of the abdominal aorta into the inferior vena cava or a traumatic rupture or even after surgery. Fistulas can also be there after an intervention, but these are usually closed after the procedure with a device. Discussion on mechanism of McConnell sign in pulmonary embolism and reverse McConnell sign. McConnell sign is hypokinesia of right ventricular free wall noted on echocardiography with sparing of the apex seen in acute pulmonary embolism. Three mechanisms proposed for the McConnell sign are: 1. Tethering of the right ventricular apex to the left ventricle, which is hyperdynamic. 2. Abrupt increase in afterload causing the right ventricle to assume a more spherical shape to equalize regional wall stress. 3. Localized ischemia of the right ventricular free wall due to elevated wall stress. Echocardiography has low sensitivity for the diagnosis of pulmonary embolism, but accuracy is higher for the diagnosis of massive pulmonary embolism, especially when decision regarding early thrombolysis has to be taken at the bedside. The gold standard now for diagnosis of pulmonary embolism is computed tomographic pulmonary angiography. But since it is not available at the bedside, it may be difficult to obtain in a person who is very sick and hypotensive due to massive pulmonary embolism. In such situations, if McConnell sign is present, it may add more value for the presumptive diagnosis of pulmonary embolism prior to thrombolytic therapy, which has a potential bleeding risk. Though McConnell sign is useful in the bedside diagnosis of pulmonary embolism, it is not pathognomonic. It can occur in right ventricular infarction as well. A study compared 107 cases with pulmonary embolism in group 1 and 54 cases with right ventricular infarction in group 2. McConnell sign was noted in 70% in group 1 and 67% in group 2. The sign was absent in 37 cases of pulmonary embolism and 18 cases of right ventricular infarction. Though the sensitivity was 70%, the specificity was only 33% in this study. A reverse McConnell sign has been described in Takotsubo cardiomyopathy. Basilar and middle segments of the right ventricular free wall were hyperkinetic and apex hypokinetic in the same manner as in the left ventricle. This discordant motion opposite to that of McConnell sign in pulmonary embolism has been called reverse McConnell phenomenon. Reverse McConnell sign is associated with worse right ventricular failure symptoms in Takotsubo cardiomyopathy. Authors mentioned that this phenomenon may also be found in some patients with severe and acute cardiogenic shock without Takotsubo cardiomyopathy. Here are the first set of journal references. Second set of references are here. 60/60 sign on Doppler echocardiography in acute pulmonary embolism. 60/60 sign in acute pulmonary embolism is a pattern detected by Doppler echocardiography indicating a disturbed right ventricular ejection pattern. The sign has two components. One, tricuspid regurgitation jet gradient of less than 60 mm of mercury. 2. Pulmonary flow acceleration time less than 60 milliseconds. It may be noted that TR gradient should be more than 30 mm of mercury to indicate pulmonary arterial hypertension due to pulmonary embolism. High TR gradients may indicate chronic thromboembolic pulmonary hypertension, especially in the presence of right ventricular free wall hypertrophy, which would suggest long-standing pulmonary hypertension. False positive results have been noted in pulmonary fibrosis and acute respiratory distress following lung resection. 60/60 sign was noted to have a sensitivity of 25% and specificity of 94% in one study, compared to 19% sensitivity and 100% specificity for McConnell sign. But other studies have shown false positivity for McConnell sign, as RV free wall hypokinesia or akinesia can occur in right ventricular myocardial infarction as well. McConnell sign is hypokinesia of RV free wall with relative sparing of the contraction of RV apex. Here are a few relevant references. Discussion on CT triple rule out. CT triple rule out is an ECG gated multi-detector computerized tomographic scan which can be used for patients presenting to the emergency department with acute chest pain. Three important potential causes: aortic dissection, pulmonary embolism, and coronary artery disease constitute the triple rule out. It can be done rapidly in potentially life-threatening cases of acute chest pain and has high negative predictive value. A potential chance for misdiagnosis of aortic dissection with CT is the pulsation artifact due to movement of ascending aorta with cardiac contraction. It has been successfully eliminated by ECG gating and certain reconstruction algorithms. Other potential errors causing misdiagnosis of aortic dissection are the presence of mediastinal clips and indwelling catheters. Contrast enhancement of adjacent superior vena cava can also occasionally be misleading. This has been taken care of by adjustment of volume of iodinated contrast injected and the rate of injection. Though CT triple rule out is useful for assessing proximal coronaries, it is not as good as conventional coronary angiogram to visualize the details of coronary anatomy. In visualizing details of coronary anatomy, standard CT coronary angiogram is also superior to CT triple rule out. Significant pulmonary embolism can be very well picked up by CT triple rule out. Norosky and associates evaluated the diagnostic yield of CT triple rule out in an emergency setting. It was a retrospective study of all CT triple rule outs performed in one center between 2006 and 2015. 256 slice MDCT scanner with ECG gating and a biphasic contrast injection was used. 1,192 cases were included in the study. 970 were negative studies without significant coronary or non-coronary diagnosis. 139 had significant coronary artery disease of 50% stenosis or greater. Pulmonary embolism was noted in 28 patients, aortic aneurysm in 24, aortic dissection in 4, and pneumonia in 20 patients. Of these, 30 cases of pulmonary embolism and aortic pathology would not have been detected on CT coronary angiography. Russo and colleagues studied the feasibility of CT triple rule-out in an emergency radiology setup, comparing the diagnostic performance of cardiovascular and general radiologists. From a study of 350 patients presenting with acute and atypical chest pain, concordance rate was 100% for acute aortic syndromes. General radiologists could exclude with good diagnostic accuracy the presence of obstructive coronary stenosis. This was without the use of time-consuming software and or reconstructions. Here are the first set of references on CT triple rule-out. Second set of references are here. Discussion on inferior vena caval filter deployment. Inferior vena caval filters are deployed for prevention of pulmonary embolism in the face of venous thrombosis. It is considered for secondary prophylaxis after an episode of massive pulmonary embolism. The filter deployment can be either a temporary retrievable filter or permanent. IVC filter deployment is favored when there are contraindications for anticoagulant therapy. IVC filter can also be temporarily deployed for prevention of pulmonary embolism while thrombolizing deep vein thrombosis, especially when a large mobile clot has been demonstrated by ultrasound evaluation. IVC filters can be deployed by transfemoral or the transjugular route. Transjugular route is used when the femoral veins are loaded with thrombus or when there is a vascular access problem from the lower limb. Retrievable filters have a hook which is directed upwards, facilitating retrieval by the transjugular route. The filter is deployed with the hook directed upwards, regardless of whether the deployment is by the transjugular or transfemoral route. In the transfemoral route, the femoral vein access is obtained by percutaneous puncture and a diagnostic catheter is used to take a preliminary inferior vena cavogram. The entry points of the renal veins are localized by probing and selective injection of contrast. The diagnostic catheter is removed and a sheath is introduced over a guide wire. The IVC filter device is then introduced and positioned below the renal veins using check shots of contrast. The sheath is withdrawn gradually to deploy the filter. Further check venograms are taken to confirm the position of the filter as well as the inferior vena caval flow. Filter retrieval can be done within a period of 3 months if needed. Fluoro image after deployment of an inferior vena caval filter. Retrieval is usually done from the transjugular route as the hook is in the upper part of the filter. The hook is caught and the filter gradually withdrawn back into the sheath before pulling out of the venous system. Bedside IVC filter deployment using intravascular ultrasound IVUS guidance has also been described. In that study, they compared the technical factors in 97 IVUS guided and 98 fluoroscopic guided IVC filter deployments. They found that IVC filter malposition was more likely with left femoral venous approach compared to jugular and right femoral venous approach. Hence, they recommended avoiding the left femoral venous approach. Discussion on intermittent pneumatic compression for DVT prevention. The risk of deep vein thrombosis and pulmonary embolism can be reduced by giving intermittent pneumatic compression of the calf muscles. The authors analyzed data from over 16,000 patients in 70 clinical trials to assess the benefit of giving intermittent pneumatic compression of the lower limbs in preventing DVT. They also checked the additional benefit of adding pharmacological thromboprophylaxis. Intermittent pneumatic compression reduced the risk of deep vein thrombosis from 16.7% to 7.3%. Pulmonary embolism was reduced to 1.2% from 2.8%, that is an absolute reduction of 1.6%. It was also more effective than thromboembolic deterrent stockings. Intermittent pneumatic compression was found to be as effective as pharmacological thromboprophylaxis with an added advantage of lower bleeding risk. Combining pharmacological DVT prophylaxis and intermittent pneumatic compression further reduces the risk of DVT. The number needed to prevent one deep vein thrombosis was 11, while that for pulmonary embolism was 63 with intermittent pneumatic compression. Intermittent pneumatic compression device has cuffs applied to the legs and tubings attached to a motorized device. The device provides intermittent inflation and deflation of the cuffs so that intermittent compression is applied. This will facilitate venous return, which should normally occur due to contraction of calf muscles in an ambulant person. Thus, the device enhances venous return and helps in prevention of stasis and thrombosis. A Cochrane systematic review assessed the combination of intermittent pneumatic leg compression and pharmacological prophylaxis for prevention of venous thrombosis. They included 22 trials with 9,137 participants, of which 15 trials with 7,762 participants were randomized trials. They found moderate quality evidence that combining both modalities compared to either modality alone decreases the incidence of DVT when compared to compression and incidence of pulmonary embolism when compared to anticoagulation. Effectiveness of intermittent pneumatic compression was also documented by the CLOTS 3 trial in post-stroke patients. This was a randomized controlled trial in 2,876 patients at 94 hospitals in the United Kingdom. Another meta-analysis of critically ill patients included 5 randomized controlled trials with a total of 3,133 patients. They found that intermittent pneumatic compression alone, anticoagulation alone, and the combination of the two were associated with significant reduction of DVT and pulmonary embolism compared to no treatment. But there was no significant difference between these modalities when compared together. Stop leg clots, a Swedish multi-center trial of outpatient prevention of leg clots, is a randomized controlled trial of intermittent pneumatic compression in lower leg immobilized patients. They plan to enroll 700 patients in each arm, and study completion is expected by the end of 2022. Subjects will be those with either an acute ankle fracture or Achilles tendon rupture. Discussion on May-Thurner Syndrome or Iliac Vein Compression Syndrome. May-Thurner Syndrome denotes iliac vein compression by the crossing iliac artery at the iliocaval junction. Usually it is the left iliac vein which is compressed by the right iliac artery. The compression increases the risk of deep vein thrombosis. Other names for the syndrome are Iliac Vein Compression Syndrome and Cocket Syndrome. The obstruction may cause varicosities in the affected limb and ulcers due to chronic venous stasis. The pulsations of the overlying artery causes intimal hypertrophy of the vein, which adds to the severity of obstruction. Some reports show that deep vein thrombosis occurs 3 to 8 times more commonly on the left side. The original report was from May and Thurner in 1957. May-Thurner syndrome should be thought of in the differential diagnosis of edema of the left leg, and the diagnosis can be confirmed by venography. A report of right-sided Cocket syndrome was described by DuPont and Associates. According to the authors, Cocket and Thomas described iliac vein compression syndrome and named Cocket syndrome in 1965. It was seen on the left side and mostly in women during second to fourth decade. The patient presented by DuPont and Associates had an uncomplicated right-sided Cocket syndrome, which was successfully treated with balloon dilatation and stenting of right common iliac vein. Patient improved and was fine at 6-month follow-up. Since May-Thurner Syndrome is a progressive disease, surgical options like vein patch angioplasty and repositioning of the iliac artery have been tried in the past. Implantation of a self-expanding stent in the iliac vein is another option as described above. Zhu and colleagues reported mid-term and long-term data of 412 patients with Cockett syndrome. Of these, 231 had acute left iliac femoral vein thrombosis, while 181 had chronic venous insufficiency. Endovascular treatment with venous stenting had good mid-term and long-term results. Follow-up period ranged from 3 months to 8 years. 89 patients who had valvular incompetence of left superficial femoral vein needed a second stage femoral valve repair. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.